It's my pleasure to be joined this evening by Katherine Forch. I think most of you know Katherine. I've forgotten to introduce everybody else in these webinars. So Katherine's a physiotherapist with a special interest in concussion. Oh, there's a child in the background.
Shut
That used to be a kind of like embarrassing thing, but now it's just normal. Anyway, Katherine has a special interest in concussion and vestibular physiotherapy, treatment of vestibular and cervical issues. So welcome, Katherine, and welcome to your daughter as well. I think that was a daughter.
Yeah, that was Tess. Thanks.
And Dane Baker, who is a dietitian, who spends some time with us at Access, but also spends some time working with rugby and a variety of different high performance sports. So welcome to you, Dane.
Cheers. Thank you.
We've got some questions that have already come in on the email today, which we'll get our way through. Just remember, we've got two options here. One is the chat down the bottom. So if you want to share any sort of peaks or pits, that's the place to put your peak or pit for the week. And then if you want to do some questions to Dane or Katherine, down the bottom at the Q&A is the place to look for there. And then I think I might try and launch a poll halfway through. So keep an eye out for that. You can answer the poll anonymously if you want to. But just kind of, we were talking about whether people were planning on seeing patients at level 3 and what the kind of mood in the camp was. So I kind of thought it might be good kind of auditing the community in a very unofficial, off the record kind of way. So what we might do is crack on and get Dane into it with his nice flat peak.
Where am I? Sweet. Share.
So Dane's going to talk, do a little bit of case-based learning, which is apparently one of the most effective ways to learn. And I think these are actual cases. Dane, have you used Zoom before?
Yes, I've just got lots of screens going on. They're going on the different screens.
Because if
Is that
not,
working?
I can see you want to start your slideshow probably. Beautiful slides, like them.
Is it not coming up?
You just need to start the slideshow, I think is your main
Oh
issue.
yeah, I've got it coming up.
It doesn't matter. I was doing a talk this time on Sunday night actually, and I was sharing a complete wrong screen in the Malaysian Society of Sports Medicine. And then someone sort of poked up maybe 5 minutes into it, said I was sharing the wrong screen. It had all my notes, like just absolute gibberish I've been sharing with the world. It's good.
Sorry, I've just had a bit of IT issue here.
Yeah, well, maybe we should let Katherine go first.
Here we go. Oh, I've got it.
Here we go. Oh, no, it looks the same.
Yeah?
This is your current pit. There you go. Perfect.
Sweet. Okay.
So rain was your pit.
I'll get started.
That was now.
Good start.
Good.
Yeah, so I'm going to, so my name's Dane. I'm a dietitian at Access. So I'm going to take everyone through 3 case studies today. So hopefully we get a range of different sort of patients that we see. And yeah, just show some examples, I guess, of probably the good ones that come out well. And just, I guess, the general kind of philosophies or, yeah, a lot of the common threads that we see in all these patients, and hopefully just explain that. And then maybe at the end of each mark, you can just, any questions that come through. So the first one we're going to go through is sort of the old classic, the adolescent rugby player. So here we've got a 15-year-old, so sort of midway through year 11, on the verge of first 15. So he's been spelled out that he could be in the first 15 next year. He's a loose forward, 82 kilograms currently, so pretty good body weight. Wants to make the team next year, is highly motivated. He's been given feedback by the coach that he needs to get more physical presence over the ball, move some bodies, compete physically with Auckland first 15. And he's a loose forward, so he's an open side flanker. He's also an elite water polo player, so he plays multiple sports, which most of these young athletes do. He trains pretty heavily for water polo, and so we'll cover that a little bit more detail. He's got a constant level of fatigue. He's got multiple trainings per day. His father's concerned that he's been told to take creatine to gain muscle. He's not convinced, and he wants to know, can he gain muscle with diet? So that's sort of how the case presents. So considerations for these athletes is they're often extremely busy. They're active at school. He's a young athlete. He's doing a lot of trainings. He's doing a lot of water polo training, which we'll go into just the volume of that. He lives quite far away from school, so he's got about a 30-minute drive or bus to school. He's doing a lot of exercise with a lot of muscle mass, so he's burning a lot of energy. So as a sort of crude measurement, some of these sessions, like a single session, he might be burning about 1,200 calories in exercise. And when he's got some of these double day sessions where he's got water polo, then he's or he's rugby first and he's at water polo in the evening, he's got gym in the morning, he's easily burning close to sort of 2,500 calories a day from his training. He's poorly organized. He's got massive appetite in the evening from his dad's a bit worried about. He's tired. He's got lots of training and little time. So what did we do? So the key thing I like to do with these athletes is with everyone is we use energy availability as our key mark. So what we can do here is we can set a high energy availability that's going to allow to fuel his muscle to get through the training and to add on a little bit of extra energy in that energy budget to allow for growth. Plus, I also just throw in a bit more energy because they're often just so active during the day at lunchtimes. So we might target this guy on his plan. We're sitting at about 4,500 calories. And then up to about 6,000 when he was doing triple training days. And thankfully, those triple training days stopped pretty quickly when he realized that he couldn't do everything all at once. But we use these as guides, but obviously our nutrition plan is based around food than him counting calories. Key thing was consistency at school, being well planned, morning, afternoon, pre-training. When you need to eat like this, it really comes down to really consistency because there's just so many trainings and so much food that needs to be eaten. A big priority on distributing his protein across the day. In recovery, a real key thing is just logistics and convenience. So we'll use a lot of sort of high calorie meal replacements. And sometimes that can just be as simple because he's having to take so much food to school. He's expending so much energy. He's got no appetite that in between, especially like when he goes straight from rugby, straight to water polo, straight to dinner, we can get an easy kind of first phase of recovery in that's going to give him good source of protein, carbohydrates, and important source of energy. For these long trainings, most of his water polo and his rugby, we're going to start fueling during the session with carbohydrate. That's going to optimize the session, but also give a valuable energy source. And then pre-sleep, so we can get a nice little snack in before bed. That's really important. And also, he's going to need to be really organized before school. So especially when these athletes are training before and after or before school, having that before and after snack and maybe an extra snack before school starts is really important. So that was sort of his key priorities that we were working on. So these are his results. So really, I'm just there to kind of feed the stimulus, and we don't really know how it turns out. He saw me in the first one of our lockdowns earlier in the year, was by telehealth. And then, so he was 82 kilograms. And then in about 7 weeks or 6 weeks, he's put on about 6 kilos. And then the last time we saw him was 18th of June on telehealth again, where he's about 91 kilograms.
Do you know,
and so his report is he's feeling good.
Sorry, Dane, I think that's actually my stats from lockdown to lockdown as well.
Yeah.
Started off at about 82. Yeah.
Yeah, you'll be the first 15 next year.
Yeah, I didn't even need to see you about it.
And so I guess probably the one thing that you often see here is like, am I gaining too much? And I'm like, well, I'm not a strength and conditioner. But what I often see in these patients is there's not really any clarity of how they're training and what they're training. So I'm lucky enough, I've got a few sort of specialist friends that kind of see these athletes. So I'll refer them on to them. And his priority now for the next sort of 3 or 4 months before preseason really starts is really focusing on his rugby specific S&C, his fitness, conditioning. So he's building muscle, but now trying to get really rugby specific. And that's a bit of a challenge, I think, at high school sometimes with certain schools. So that's the rugby one.
So I just had a question come in about we were talking before we started about this case and, you know, how sensible it is for 15-year-olds to be training that much and putting that much focus into rugby. But, you know, how tall is this athlete? Is he?
Yeah, so he's about 187 or 188. So I'm about 188. He was pretty much bang on the same as me. So I mean, he's a tall, lean athlete. And you can see here, this was his numbers. So we couldn't get any measurements first up, but you can see his sum of 8, which is That's like they're younger, so they're always a bit leaner, but he's extremely lean for that sort of muscle mass. He's still running a good Bronco. He said conditioning he's good. He's obviously got a big tank from his water polo. But yeah, it is a good. Really, I was surprised that he gained that much muscle, and probably that result of that's coming from his stimulus at school. We are seeing a lot of these guys doing a lot of training, a lot of gym work early on.
Cool.
Whether that's good or bad.
And I just noticed another question in the chat. And remember, the chat is strictly for peaks and pits, and the Q&A is for helpful questions. So just good from you, Hannah, just reminding me about that, was just around creatine. So what did you tell us, Dad, about creatine?
Yeah, so creatine's a tough one. I'm definitely of the ilk that really until you're 17, 18 to avoid sort of ergogenic aids, there's just not really the safety data for any adolescent athlete. Creatine is the one supplement we've got a lot of safety information of sort of 30 years. We know it's a pretty safe supplement if it's used at the right doses. But I think here you can see very few athletes are eating at the optimal level. And I'll sort of explain, well, maybe you use that ergogenic aid when you get into your first year of club or you're playing representative rugby, that you can get that added effect. But really the priority at this age is just optimizing their diet, and they can easily gain muscle with food. Yeah.
And what do you reckon about the message that you're sending, asking a 15-year-old to start supplements of some kinds?
Yeah, well, it's coming from the schools. So some schools are better than others, and it's a real mixture. But there is a lot of desire for creatine at schools. It's always probably last 15 years. It's always been there. It comes and goes depending who's there. But one of the things with New Zealand Rugby is we have a policy of anyone under 18 years of age to not rely on supplements. So that's sort of, I think, a nice, and that's sort of supported in Sports Dietitians Australia have a similar position stand, where the grey area is probably sports foods, and that's probably more meal replacements, protein supplements, where in a lot of these bigger athletes, that's really like a convenient source of energy when they're doing this much exercise, where some people easily don't need meal replacements, but and with this amount of energy, it becomes a pretty key piece.
So two questions that directly relate to that. So one is around what did you recommend for snacking, and what type of high calorie meal replacements did you suggest?
So we'll use like he'll be, as an example, we've probably got him on about a 600 calorie replacement after, and I'll give a range of like 6 or 7 different options. I'll give how he could do that with food. So we might use like a lot of the meal replacements will be protein, and they'll have added like multidextrin, which is just a simple carbohydrate. So like Masashi Bulk might be one. There's a good one we use at the moment with the Blues. It's PVL Gainer, which is really just a variety of different types of carbohydrate powders that go in there. And 99% of the population do not need a weight gain product, but some of these guys do to consume that amount of energy. Or that could be the equivalent to like 4 or 5 Weet-Bix with milk and a banana, or it could be like a mammoth chocolate milk and a handful of nuts. So there's all sorts of ways you can do this. And then it's kind of, but we're also giving them sort of batch tested products, so we know it's all safe and ready to use. And because he's 90 kilograms, his muscle mass and his digestive system can hold that pretty well.
So that's a good point about batch testing. Do you want to just quickly clarify what that is?
So we'll recommend, especially if they're an elite athlete, not necessarily for just your recreational kind of marathon runner, sub-elite, but so informed sport, I should say, informed sport website means that every batch you take will be batch tested. So you can look for the informed sport logo. Also, there's other products, Hasta, they'll do a batch tested range. And they're basically, what it means is that any ingredient in there isn't going to be contaminated. So it's a key priority for especially our young elite athletes to be looking at.
So it doesn't mean it's a guarantee, guys. It just means that it's the batches that they test do not have any contaminants, right? So
Yep. It's been independently tested, so that batch has been tested. So you're doing everything you can, really.
Yeah, but you do not know that you're getting a product from that batch, do you?
Yes, you do. So if you do informed sport, that in particular batch has been tested. Informed choice, which is like their sister program, means they'll do random testing. So it means it's 99% safe, all the facilities tested, but the informed sport means you can use that number and go, hey, this product's been tested.
Cool. So I think that's all the questions for that case. So
okay, sweet.
I'll quit interrupting.
So now we've got sort of our exercise as medicine type patient. So here we've got an example. We've got a 56-year-old male, 96 kilograms, BMI 28.7. So this is just cut and pasted off the surgeon's letter. So if there's anything wrong here, don't shoot me. So he has early post-traumatic changes in the left hip. So a couple options for him for recovery. Key thing the surgeons talk about is weight loss. Patient wants to hold off injectables, review in 6 months on how he is progressing. So that's the sort of reason for referral. That's probably pretty common in a lot of some of the ones we see. So a little bit of info on the patient. So he works in sales, works online from home. So he works sort of irregular hours or just long hours, I guess. So he can work from home a lot. So like a lot of people are doing more and more of. He's a real fitness enthusiast. He's never had to worry about his weight, which causes a lot of anxiety for these patients because they've often been really fit, healthy. They can enjoy a bit of alcohol and never have to worry. And then they get these injuries and things can change pretty quickly. So he's got a high level of frustration and he gets really frustrated when he can't train. And that was some of his frustration. Can I lose weight on days that I can't train because that hip gets a bit grumpy? He feels like he eats a really healthy diet. He's kind of Mediterranean background. He's used a bit of intermittent fasting and he still believes in that. He doesn't eat till midday. Well, that's what he tells me, but he has about 2 or 3 coffees before midday, like a lot of people do, intermittently fasting. He's a grazer, not a big eater, so he's a constant grazer. Not a big drinker, but he'll have daily alcohol consumption. And he works and grazes quite late into the evening. So what did we do with this guy? So key thing with any of our weight loss is trying to create energy control and portion control. So portions to help meet that energy budget. And essentially weight loss comes down to appetite control and trying to get through the day where you feel high level of satiety and feel full and you enjoy what you do. So I try to tell patients if you're going to eat this way and there's no way that you can see yourself eating like that in a year's time, then there's no way we're going to get sustainable weight loss. So he was highly motivated. So sometimes I think with weight loss, it's good to kickstart weight loss, especially if they're coming from a healthy environment, not like sort of our low energy availability patients. So we've set a sort of pretty moderate energy availability of 25. So that looks like on a day where he doesn't exercise, he's eating 1,500 calories. When he can do his mobility training in the morning, functional training that's been prescribed by Hannah, he might eat 1,700 calories, and then he's eating 2,000 calories when he does his double day. So what I've told him, if he feels grumpy, if he can't exercise, then follow his 1,500 calorie regime, and then we can bump it up a little bit for different days. So really trying to individualize it. I convinced him to try a different focus with his intermittent fasting and just really focus on evenly distributing his energy intake. That caused a bit of conjecture. He wasn't too keen, but I just put my foot down and said, let's try it. Let's see how it goes. And with real key focus on protein and distributing his protein evenly over the day. We also threw in a bit of collagen supplementation with breakfast because he was training sort of mid-morning. So it may be worth putting in there. Key focus, like I said, was protein intake, especially with breakfast. So got him having a high protein breakfast, but probably we're thinking probably like 400 calorie meals split up across the day with a couple of snacks. He wasn't a big lunch eater, so he started just buying his lunch. So there's a lot of good homemade meals you can get delivered that have a really good source of high protein, lean meat options with good quality vegetables. So he just used that as his lunch. And the big focus was his nighttime eating. So simple strategies we had: no training day, he'd just have his dinner and that was him for the night. If he had one training, he could have like one snack in the evening. And then if he did his double training day, he'd split up and have a couple of snacks. And kind of convinced him with his alcohol to maybe just think about having alcohol on the weekend and maybe tie it in with those days when he can get a little bit more exercise in, but to still work it into his total sort of energy budget of sort of those different measurements and using those with his snacks. Would sort of educate the patients around alcohol and how that has a big impact on appetite and also just how it changes metabolism to sort of increase fat storage a little bit. So this was quite recent. So his follow-up was supposed to be next week for his sort of 7 or 8 or 9 week follow-up. But pretty much in that sort of 6 weeks, he's lost about 5 kilos. So yeah, really awesome results that, to be honest, I didn't think he'd achieve. he was really keen on body comp assessment. So this is skin fold. So there is always a bit of error, and these are pretty crude measurements of body fat. But you can see here, skin folds have come down a lot. So these measurements kind of tell us that almost about 95% of that weight is fat, and we're not chewing into any muscle mass, which is pretty good result. So he's emailed and said he's on track. He's really happy. So I would be hoping sort of for 12 weeks that we could get pretty close to that 10% body weight. And then, yeah, let's see how that affects his sort of hip. And but a lot of these are key things that we're sort of working on. We're working on consistently with a lot of our patients with that sort of weight loss when they're struggling with injury.
So there's quite a few questions coming in about this particular case, probably for a friend, I'd say.
Sweet.
So for a friend, a question from me is like, what does a 2,000 calorie diet look like? Like, could we still be having half a block of cheese in the evening?
Yeah. To be honest, all right, the biggest gains people make is their grazing. So they'll be like, have wine, cheese, and that when you start showing them what a serving of cheese is, like I'll kind of work in calories with snacks, like this is one portion of snack, this is 2 portions. And once they start seeing what portion of cheese it is, you can eat cheese and they'll use it as a snack, but often it's that snack can start looking like 600 calories pretty quick.
Shit. Okay.
And the challenge is a lot of them have been able to eat like that because they've just been able to expend the energy. But when you are now limited, you can't go for that 90-minute run. It makes life a bit different.
And how many calories in a craft beer are we talking about?
You've sort of 4 to 5% is about 150 calories.
Sheesh.
So the good thing is with light beers, so the quickest way to reduce calories is reduce alcohol percentage. So the mid-strength beers have been a good way to kind of still be able to enjoy a few beers and keep to your calorie budget. Not too bad.
What's the sugar though, I hear?
Yeah, but it's the percentage sugar, but it's the calories that are just the whole low carb beers.
Anyway,
bit of a myth.
Tell me about the difference between tell us about the difference between between collagen and gelatin.
Yep, so collagen and gelatin are the same thing. So it just means that the collagen has been sort of hydrolyzed. So it means it's just going to mix with water a bit better.
Cool.
Where your gelatin will be exactly the same. There's been research which has shown the digestion is pretty much exactly the same. It's just if you want to pay $80 to mix it with water a bit better, which some people do, then go with your collagen.
And how about what supplement would you recommend for collagen?
We use the kind of, I'm trying to remember off the top of my head, we use sort of batch tested ones because we're dealing with athletes a lot of the time, but we like, you can get any hydrolyzed collagen off the shelf that should be pretty just classic collagen. That should be well digested. A good one is there's Thankfully Nourished, it's from Australia, it's batch tested, it's reasonably priced and it mixes really easily.
Tastes amazing.
So, yeah, it tastes just like water, yeah. But remember, collagen is not going to help muscle protein synthesis. So don't start taking your collagen after exercise or think that's going to help maintain muscle. It's really just that specific intake to maybe help connective tissue synthesis. So
yeah, and you did open the door a little bit to talk about fasting, and so I've got about 5 questions about fasting.
Yep.
So just generally, what's your opinion on intermittent fasting? When might you recommend it? And when's the latest in the day you'd suggest someone eats?
Yeah, so I'm probably a bit biased because when I see people, they've come to me because things aren't working, and often they've been trying different things. And what I see, I think intermittent fasting can work. It can be a unique tool to restrict calories. And I guess if they're seeing me, then we can do it a bit more specifically to them. If anyone, I think John Hawley puts it good. If you're a rat or a fly, fasting is quite good for your health. But there hasn't been as much research in humans. The one thing we see with intermittent fasting with muscle mass is when we see it in humans is we're losing weight, but we lose muscle mass. So that's a bit of a problem. And that's just because there's just a long period of time without any protein to the muscle, and that's just reducing muscle mass. So if we lose muscle when we're losing weight, that's going to reduce our metabolic rate. It's going to put us in a reduced state to keep losing weight. So I think if I did write an article on sort of time restricted feeding, which I think is a lot better. So I talk about like an eating window where getting people to eat earlier in the day, but they might reduce the last meal of the day. And that's when often the damage is done with post dinner, when, especially if you're not an athlete and you're not training in the afternoon or the evening, just focus more of your nutrition earlier in the day. Set up your day, control your appetite with more protein.
I'm feeling a
Even
little
though-
attacked in this conversation, Dane. I
Because
do like love my after dinner snacks.
I know, I'm just
Yeah,
planning on what I was going to eat after this. I'm really.
But if your goal is weight loss,
settled
that's
down
the thing. It's all about, like, if that can be an easy area to kind of look at, and setting up your day earlier to control your appetite is important for the evening.
All right. I'm conscious that we're eating into Catherine's time, but just for that last case, would you change that much for women, or is it more just around?
Yeah, so I would go, definitely, we know that men can be a bit more tolerable to lower energy. And so with female, I would be going a little bit more moderate, and just trying to get more gradual, safe weight loss. And yeah.
Okay.
Definitely.
So cracking on. We'll keep these
Cool.
questions. I know
Last
there's
one
still a
is
few
more from the performance side of things. So this has been an interesting patient I work with. So I just saw him yesterday. So I got a bit more information that's kind of in his words, which is good. So 42-year-old marathon runner, 85 kilograms, says he's lean, no problem with body comp. He came to me, he wants to run a fast marathon time. So he's an interesting case. He's taken 2 years off work to support his wife. She's a lawyer. He's a GP. So he's been taking the kids to school, running during the day. His world came crashing down at level 4 when he had them at home all day. So that's changed his performance a bit. But so his history was, he completed the Comrades Ultramarathon in 2018. He tried the high-fat, low-carb diet for the 12 months prior to that. And he's gradually moved back to kind of a mixed diet since. He reported that he'd lost weight during the high-fat, low-carb to 79 kilograms, but he struggled with injury. Couldn't necessarily specifically say it was due to his diet, but struggled with ITB, plantar fascia. He self-reported he overreached. He wasn't happy with his performance. He got through the race, but yeah, wasn't a big fan. So his key focus now is on marathon distance. So every 6 months he's training for a marathon, or he's targeting a specific marathon, and he's working with a coach with that. So he's a sub 3 hour pace. So he's a good runner, and he's really taking it seriously. He reports he says he feels flat. He's stuck with his diet. He was really frustrated with a poor performance in Christchurch, and that was really the catalyst for seeing me. He feels like he's in a constant restriction mode, and he feels like that's a hang up from the high fat, low carb. When he's plugged his diet through MyFitnessPal, it's consistently coming up with more than 50% of energy coming from fat. And so he's like, let's figure this out a bit more. And he struggles to maintain high training loads. Every time he gets up there, he gets an injury, or he has to stop training to some extent. So he's not focused on body weight. He just wants to fuel. So what did we do? So we use energy availability with all our patients. And then we also, key focus is with that, we're using a sort of a mixture of carbohydrate to promote carbohydrate availability. So this is what it kind of looks like. His recovery day might be about 3,600. And then to his tempo day, about 4,300, 5 to 6 grams of carbohydrate. These all kind of estimated off sort of the fuel plans. And then you can see his Sunday, his big day, we're up to sort of close to 5,000 calories. These are his baseline nutrition. So a big focus was on recovery. A lot of his runs are all mid-morning. So we really ramped up his recovery protein with additional carbohydrate to replenish glycogen. We had him snacking twice in the afternoon with a pre-sleep protein smoothie, and really focusing on how he can balance his plate to get a bit more carbohydrate in there. We tried to do one fasted training session per week, which he enjoyed, but then just found that he couldn't do that. So the main reason we're doing that is to try to maximize some training adaptation, maybe in a fasted state. But he only did that early in the training block. So he thinks that would be something he would do early on, and then flags it once he starts really getting into it. His performance nutrition strategies were, we worked a lot, and we're working currently a lot on his basically exogenous carbohydrate availability, which is basically a flash word for fueling during exercise. So we're working on 60 grams an hour. He's using Morton Sports Drink. That's his individual preference. We're replicating that as pre-fueling for big runs, training the gut with his pre-carbohydrate intake, with what he's eating before he trains on the weekends and also during. I've done a bit of work trying to understand his sweat rate. So he's aiming for about 700 to 800 mils per hour. So he's obviously going to get dehydrated, but this is a level that he can tolerate and get his carbohydrate in. We're working at the moment with a few sort of key pieces that he's trialing with his time trials around his carbohydrate loading for 24 hours prior. So we're using sort of low residue carbohydrates that are going to avoid weight gain. Also looking to maximize his caffeine intake. So he's never really used caffeine before. So we're trying to look at 300 milligrams, 100 milligrams prior to race. And then he's using the Morton Sports Drink, which he says is really a good way to do this. So he's getting about 100 milligrams per hour. Okay, so this is his progress. So this is all kind of reported from him. So there are people out there that know more about this information than me. So you can see up here his weight. So really interesting, like he's really ramped up his carbohydrate, but his weight's completely stable. And I reckon he's probably increased his calorie intake by about 20, 30%. So I reckon his metabolism's just increased because of this. Chronic training load. So he said it will peak at 77 this month. Last block was 67. So he says he's been able to handle 20% more volume. This is the first time he said he's been able to manage 6 weeks of 100 kilometers plus in a 9-week period. So he's really happy with how much he can train. His anaerobic threshold block was 342 minutes per kilometer, now down to 334. So he said that's the difference between race day pace of 4 minutes. Previously, 6 months ago, it was 4 minutes 12. So he said that's about an 8-minute improvement, which he's very happy with. He said key things for him have been more fuel, more protein, more frequently during the day has made a big difference in performance. He sleeps better. He said he's got a far better mood during the day, which is important for us that have to look after those little kids. He said he sleeps a lot better. He also said it's really kept his overuse injuries at bay as well, whether obviously there's a lot of other factors in that. But yeah, really sort of interesting case around now he's running marathon compared to ultra, just the importance of carbohydrate and fueling. And so just for anyone interested in this, like this is probably one of the best papers you can read to give all of this information, like 30 years of research in these IAAF consensus statements. You can see there's a whole lot of them. These are all free access on all the different areas, but this one in particular on nutrition strategies for distance running and race walkers, it kind of just compiles all the evidence, which is an awesome review. So that's me.
Awesome. What we might do is just keep these questions until the end so that Katherine can crack on and have a bit of a go. So do you want to quit sharing your screen, Dane, or?
Yep, I'm just going to find I've got a different screen here.
Do you want me to do it?
Yeah. Where is it? I've got different buttons.
I've done it. Don't worry.
Cool.
I've binned you.
Cool.
So just maybe while you're getting ready, Katherine, I'll maybe ask you a couple of questions. I'll stick this poll out there as well. Remember, you can answer anonymously. It's just lots of people have been talking about what they might do next week if we go to level 3. So I thought it might be kind of interesting to get a bit of a group consensus as to what they were thinking about doing. And that's segued nicely into your talk there, Katherine. So the floor is yours.
Oh, are you just going to run the poll in the background?
Yeah, in the background. Well, it's
Okay.
really going for it.
Cool. All right. So the loose brief from Forch was just talk about some tips and tricks. So I thought I'd quickly talk about kind of how I explain to people what a concussion is, because I know from some of my workshops that I teach that can be quite tricky for people. And then I'm going to rattle through a couple of cases. I have to say my slides aren't as pretty as Dane's, so I preemptively apologize. So as far as
get your kids to run in the game, isn't it?
Yeah, give you a small naked child's butt to just if anyone was half asleep. Cool. So we've kind of moved on from this, bowl of jelly that gets shaken into the sides of the box analogy. That is what certainly I understood of concussion probably when I first got into this more neurophysiological model. So to take us all hark back to neuro at undergraduate level, we understand about the structure of a neuron there, and we've got these ion channels. So normally, this action potential gets moved along the ion channel by ions moving along the axon, by ions moving in and out, getting that depolarizing happening. But when we have a concussion, when this impact is transmitted through the brain, basically, if we still think of that jelly, it's more about the jelly actually warping. And so each individual fiber gets kind of a tweak. And so some of those channels get opened and some of them get closed. And we basically just get this massive influx of ions in and out of the cell, and lots of aberrant firing. So I use that sprinkler analogy a fair bit to patients. And essentially what that works out to be like is a fireworks display. So they burn up all the fuel at once. And then we have this period of time where your brain is in a bit of deficit. The easiest way to understand it is glucose as far as the fuel, but there's a few more other, where you have a deficit for glutamate, calcium, potassium, all sorts of things. But we have this period of time where the brain wants lots of fuel, the demand's gone up, but actually the cerebral blood flow goes down. So it's a bit of a mismatch. And that's often why people have that crash straight away. And then slowly, as those levels start to recover a little bit, they recover some of their functioning. But typically it's this fuel hungry kind of inefficient brain scenario that drives a lot of the symptoms that we're experiencing. So sprinkler and fireworks is probably my two analogies for that one. Everyone knows I love an analogy. If we shift gears a little bit and just talk about a bit of a necky case, this guy did have concussion, a history of concussion, but you could apply some of what we're going to talk about to any of your necky patients that you're seeing on telehealth. So this guy had a injury 3 years ago and he's got ongoing symptoms, so persistent post-concussion symptoms. And when I was first chatting to him, he said, I've got headaches everywhere, it's all over the place, all over. And it was quite hard to kind of pin him down to what's going on. Without getting too deep into it, he has been fully unfit for work on ACC for the last 3 years. He's run the gamut of every different person you can see for various types of intervention. And he's kind of been labeled with this hypersensitivity diagnosis. So I guess the key thing with telehealth is actually sort of trying to pin down, like you've got a bit more time, I feel like, to listen to them. So I really tried to get a bit of a deeper headache history out of them. I said, well, what are these headaches? When do they come on? What makes them worse? What makes them better? And there was a bit of a pattern that sort of started to come out. And one key thing that he mentioned was he had decided he was going to go off to the gym, and he'd done a whole lot of quite heavy shoulder press and some overhead things, and found that all of his headaches were a lot worse, but particularly this one he described that started on the left side, kind of from the back of his neck and radiated up. And then he also described this quite different sort of tension type tight band across the front of his head that those of you who've worked with these kind of people will have heard about a million times. There's nothing he was describing in his history or anything going on medically that made me think about any significant red flags. So I thought, well, this might be a bit interesting to have a little bit of a look at what's going on with his neck. And he was a really good advertisement for this. So when I did, those of you who didn't study at AUT, this is a movement diagram. So the blue means that his movement was restricted by resistance, basically. That's just where he got to. Whereas if you see a red line, it means that that was sore, provoked his pain. So when I just got him to do the movements that you see there, so work through his rotation and flexion and things, it was all right. He was a little bit kind of stiffer moving to his left, but it didn't provoke any pain. And in range flexion, he described this kind of pull between his shoulder blades, but there wasn't really much that came out of that. Whereas when we got a little bit more specific, this is what happened. So when we're thinking cervicogenic headache or a potential symptom driver being in the neck and being associated with headache symptoms, it's coming from the top 3 levels of the neck. Okay, and so we have to think about trying to isolate our range of motion assessment a little bit more down to those levels. So when the head comes into flexion, the occiput slides in a posterior direction, okay? And so we're talking about AO flexion. So the way we sort of differentiate that a little bit is the old interlock your fingers and then get them to do just a little craniocervical flexion and extension, but in a little bit more of an isolated fashion. And the minute he did that, he was like, right, well, yep, don't like that much. Okay, so the flexion brought on his pain. And then when we think of rotation, he also reported that when he was trying to rotate, so what I'm talking about here is the flexion rotation test, which looks a little bit more specifically at C1, C2, where this is going to squash my microphone, but you put them down into full flexion and then you ask them to rotate. Okay. The difficulty with telehealth is you're relying on that being an active flexion rotation test, which isn't as sensitive as the passive one. So normally if we had them in our on a plinth, you'd put them in supine, you'd fully flex them, and then you'd have a look at the rotation. But for him with that was quite restricted to that right side, okay? But his side bend was restricted to the left. So if we think of that AO trying to slide back when he's coming into flexion, when we're rotating at C1, C2, we also get a bit of a coupled motion happening there. And so he had this quite consistent pattern of some things not being particularly happy when they're being moved. So that was cool. The other thing you want to think about with telehealth, and this is a bit tricky, you have to be a bit creative with it, is how we differentiate between pain that's being driven by an active structure as opposed to a passive structure. So we're kind of talking muscle versus joint here, joint capsule, something along those lines. It's pretty hard to get them to do a fully passive movement, obviously, but you can get it going a wee bit. So typically for, if I'm looking at craniocervical flexion, I get them to kind of hold their jaw and the top of their head, and you can play along with this if you like at home. But if you actually initiate that nod from particularly your top hand pulling forward, you can actually do it reasonably passively. And in that same position, you can provide a little bit of resistance with each movement. So you're trying to differentiate. Obviously, if there's more pain when you're trying to resist a movement, we're thinking it's more likely to be the active structures, okay? If there's pain with passive but not active, we're thinking it's more likely to potentially be some of those joint-based structures. So there's a few things like that we can play around with. Forch is just choking himself in the background there. And this is quite interesting. So this was a study, this Bogduk 2009 paper is quite fascinating if you're interested in cervicogenic headache. There's a whole lot of detail in it. But basically, in this particular study, they injected saline into the back of people's necks at different levels and looked where the pain was provoked. So these were people asymptomatic normals. And if we look at the distribution, particularly at sort of 0 to C1 and C1 to C2, where the pain distribution was, it's pretty bang on where our chap was feeling his pain. So we can start to see some links in the scenario happening there. As far as what you can do with them, the nice thing if you have a look at the clinical practice guidelines is that with chronic neck pain, you can try a whole lot of different things. Okay, there's level B evidence for a variety of different options, which can include mobilization and manipulation. Bit tricky at the moment. What I did with him was taught him some self-snags. I also gave him some of those segmentally isolated assessments as a self-mode, particularly that flexion one, because interestingly, as he did a few of them, he said, oh, actually, that feels a bit better. He sort of got it moving a wee bit. I don't like to talk about postural retraining because the research is questionable about whether there's a link between your posture and pain, but movement variation I think is really important, and particularly at the moment if we're all sitting around probably more than we normally would be. It's that idea of get up and move, go do something different, sit differently, put your screen at a different height, those kind of things. He was also going to do some soft tissue release. You can get the peanut balls, or a cheaper version I tell people is to just put 2 tennis balls in a sock and tie a knot in the end, and you can lie on that in supine and roll around on it, and often you can get some quite nice sort of neurophysiological release from some of those tight points you get in the back of the neck. And then I started him on some deep neck flexor retraining. Not because I could assess that properly, because that's difficult. We can't use biofeedback in this kind of situation, but I did talk to him about what it felt like when he tried to activate his deep cervical neck flexors. So that's where we're initiating that craniocervical flexion. And he described a a very strong sensation of tightness in the back of his throat. And that's something that you quite often get when some of the muscles that are attaching onto the hyoid are trying to work really hard. And you could actually see, even in this medium, that this chap had really big developed sternocleidomastoid bellies. And we know from the literature that chronic headache, there are changes in the patterning between those muscle groups. And so I thought, well, there's not a lot of harm in having a go at that. The other key thing with this guy is that, he hadn't tried this stuff before. And so often if you give people, and this is the argument against specificity of retraining or whatever, but actually I think sometimes people just love a plan and they love having steps that they can take themselves. And that's where I feel like telehealth can be a boon in some ways for us as therapists, because you can't rely on your hands. Now, I know if this guy'd come and see me in the clinic, I probably would have just done lots of hands-on stuff and then finished off with a quick chat about some things he could do in his own time at the end. Whereas this way, the focus shifts completely in the opposite direction. And it's all about those self-reliant strategies. So yeah, that was that chap. The second one, I could think of a million different people we could discuss here, but this is a common question I get from physios who come and spend time with me in clinic, or who send patients to me, or who've come in my workshops, is that athlete you have after a concussion and they've got to the point where they're feeling pretty good and they're looking at returning to training. They've gone through that graduated return to play, they've got through aerobic stuff pretty happily, and they get into sort of team-based training and they get a massive symptom flare and they have to dial it back. And I just want to put this out here as a kind of something to think about, sort of a framework for how you can break that down a little bit more, because this is what I do basically, is just have a think about that athlete and what do they specifically need, and which of those parameters are we going to change within a session. Because if we think about someone who's been sitting on the couch for a couple of weeks because they've just been told to rest, and then they've come to Access, had some excellent advice around active rehab, got back into things, and then we're looking at putting them back into a team sport training environment. That's a big spike in load and on a whole lot of levels, whether it's autonomic function as far as the exertional responses with the change in intensity. They might be doing lots of change in direction and agility based stuff. There might potentially be some strength, explosive power components. If we think of a netball player who's suddenly doing jumping and landing and those kind of acceleration tasks. And then it's the cognitive side of things that sometimes I think we underappreciate. So I had a really good chat with a chap just last week who he plays professional rugby. He's been out for a little while and he's been working his way through this process, and he'd had a little bit of a symptom spike after a particular training session. And I said, well, what were you doing? And he said, oh, we're talking about lineouts. And that's not something that we think is a particularly aggressive movement-based task. But for him, his role in the team in that particular area of play is quite a leadership position. So it's quite, he needs to put a lot of thought into that. He might be involved in calling the lineouts, but it's certainly something where he's a lot more involved. And I think it was actually that, once we kind of unpacked that a little bit, he sort of realized that he was having difficulty with processing some of the plans and some memory type things. And so it meant that he could go away with a bit of a shopping list of what to work on for that. Whereas it may be another athlete that you think, okay, the priority for this session is I'm just going to look at movement planes. I'm going to keep intensity the same so I know they can run steady state. It spike their symptoms, and we're just going to introduce some change in direction and we're going to leave it at that. And we sort of layer it on that way rather than a whole lot at once. Because the nice thing then is if they have had an increase in symptoms, it's very easy to just pull it back one stage rather than them having to start all the way back to square one and build from there. So contact's always an interesting one. And obviously we need to be pretty confident that they have recovered before they're looking at, reintroducing contact given the risk of potential other injury. But there are ways you can break down contact. So if you think about what contact, if we think of a tackle, or in football, if you're having a clash against someone's shoulder in the air, or, and God, I played netball for years and it's certainly a contact sport. there's a lot of facets of that you can actually start to retrain before you put them into a higher risk situation. So things like preparation for impact or that sort of vibration sense. So it may be that they're doing jumping and landing. It may be that they're getting some bracing practice. So you can look at kind of boxing on a bag or something like that. And just having a little bit more of a think about how you can sort of do that in a more graduated manner rather than going from yay to 100%. Cool. And then our last one is, anyone who's worked at Concussion has seen this person a million times. So this is the very type A, highly strung, highly intelligent, highly stressful job, big expectations on themselves, wearing lots of hats. I mean, I have chosen a specific patient, but I probably could have picked about 20. And when you're looking at their symptom load, it's across the board. Everything's really, really challenging. But this woman in particular was quite a good historian. And her main issues when she was describing what was bothering her the most was this. Firstly, this kind of mood disruption. So she was feeling really irritable. She had kids and she was snapping at the kids a lot. And she was finding that she wasn't able to kind of control her emotions. She was also feeling really up and down, crying a lot. And then she described some really key things. So she said, oh, I feel like the world kind of closes in on me. Like I get this real sense of tunneling. And she described feeling really overwhelmed and overstimulated. We hear that a lot. She also said that she couldn't catch her breath. She just felt like she was constantly a little bit short of breath, and that wasn't feeling, like it normally would. She was really distractible. And this is someone who typically had very high levels of focus. Her job required some pretty full-on ability to kind of stick on one task and manage multiple tasks, but do all of them well. And she felt like she was kind of doing the opposite. She had a really marked issue with photosensitivity. She also described some weight loss, not to a point where it was, of anything of concern, but something that she'd noticed. And she was a fairly slim woman anyway, and she certainly wasn't doing anything to try and lose weight. And she had poor sleep quality. So I guess the key thing to think about with this case, that the reason I brought it up is it's this idea of sympathetic dominance that we see heaps with concussion. So she's stuck in that fight or flight mode. And there's some ways that we think of fight or flight that are relatively straightforward, but there's some other ones that sometimes we don't think about so much. Those of you out there with some breathing expertise could probably speak to some of those aspects a lot more intelligently than I could. But I sort of would sort of sum it up as people often don't feel like themselves as far as their sense of movement, their sense of themselves in their body. They feel a bit kind of uncoordinated or weird. They often describe things like difficulty going up and down stairs or depth perception or those kind of things. And the easiest way to imagine that rest and digest, or that parasympathetic state that we're kind of after, is that flow state that some of you may have experienced if you're athletic, or where things just work and it's easy and it's relaxed, and these people aren't experiencing that hardly at all. And so I guess I feel like my practice has changed a fair bit over the years, and that I don't think initially I used to respect this as much as I do now, but I think there are a lot of so-called physical interventions that we can give someone that give them a sense of autonomy and a plan and something to do, but that actually target this issue here. So we're trying to encourage parasympathetic activity. So, I mean, reassurance is a massive one, and I think that's where we have to be really, really, really careful with our language. The number of people I've spoken to, particularly long-term with these type of injuries, who've heard one phrase and they've just held on to that, and that's become a really key part of their kind of injury identity. So it's making sure we're not nocibic with our language. We're encouraging them. They're going to recover. It might take time, but they will get there, that kind of thing. Balance training. I've got there has to be appropriately prescribed. So someone told me I should have this embroidered on a cushion once, but I always tell my patients to find the wobble, not the step. So when you're doing balance training, it shouldn't be at a level where they feel like they've got to initiate a step strategy, or they're getting that kind of sense of, oh, I'm losing my balance. Actually, with this group of patients, if you're prescribing them balance training, your aim is for them to be aware of the sensations that their body is producing. So you're actually trying to get them to be aware of their postural sway, to be aware of the weight distribution through their feet, and those kind of grounding. You can tell I'm getting my yoga teacher. It's coming out of me a little bit with this. I'm trying to be less fruity so Forch doesn't give me grief. But it's for a different purpose than potentially balance retraining, where you think of a performance outcome. Okay, so this is where you might do your testing with them, and you might peel that level of difficulty back several steps to the point where they're actually not finding it particularly challenging, but you're giving it to them with a different purpose. Okay, the same thing applies there with a walking meditation. That's where you might look at like a tandem walk, that we give as quite a common exercise, but you might ask them to do that in a way that is very mindful, very slow, very aware of what they're doing. So I'll typically say, all right, I want you to try and walk along a line, but I want you to try and do it as slowly as you can. See if you can feel your foot being kind of peeled off the ground, and feel it come through and take the ground in front, those kind of things. So they're getting out of that sort of wind up fight or flight, and they're getting into their own sense of their body during movement. Breathing's really useful, completely. Like I said, there's people who are much better qualified than I am, but I think we can all talk to that simple breath strategy, slow down, be aware of how you're breathing. I would be a little reticent to change someone's breathing pattern, but even just slow down and close your eyes and feel yourself breathing. I think there's merit in that. There's also it's a yoga thing again called Brahmari breath, where you actually hum. So humming can get some vagal nerve activation, which is great. So people who are a bit open to that kind of thing, I'll sometimes get them to use that as a bit of a brain break recovery if they feel like their symptoms are getting a bit elevated. Go somewhere quiet, cover their hands over their eyes, and just do some little bit of humming. Any of that mindfulness, kind of guided meditation, sort of relaxation type stuff, appropriately done yoga. As someone who does practice yoga, it really frustrates me when people sort of have a negative experience with it. And this particular patient, I was like, look, here's something that you could try. Go and do a nice relaxing restorative yoga class. And she went to some massive big gym one where it was lots of quite aggressive flowy postures, and it was just a complete absolute balls up. She was not very impressed, and I was like, well, that's not what I was after. So as long as it's the right type of yoga. And then the kind of happy hormone stuff that sometimes we forget about a little bit. So these people, anything we can do that taps into those happy state, whether it's happy music, whether it's looking at pictures of things, good memories, bringing all of that stuff to their mind's eye, particularly when their symptoms are coming up, that can be really helpful. And then the other thing from a physical capacity that I like to give them, sometimes not because I feel like there's an actual issue with that particular function, is peripheral vision exercises. Because if we think of the function, fight or flight, the sympathetic function, we do get this real tunneling. We get very locked in and focal. Think about you fighting a tiger, you're looking at the tiger, you're not worried about what's around you. So anytime we open up awareness of that space, it's actually a parasympathetic function. So giving someone some really simple peripheral vision exercises can have twofold effect. A, it might help their peripheral vision, but B, it might be quite a nice cue for them to sort of get out of that state. And that's actually used in things, sort of anxiety training and stuff like that too. And I think there's an interesting role for it in sports as well. So if you've ever had one of your athletes go red, I've seen this a million times on the sideline, where they're just that red mist has descended and they're just making stupid decisions and they're all over the place and something's rattled them. It could be that you give them something physical, like, they're in a huddle. What can you see next to you? Are you aware of your teammates on either side of you? That kind of thing can help snap them out of it a wee bit. And this is one of my favorite comics by Michael Lunig. So what is worth doing and what is worth having? It is worth doing nothing and having a rest. You must rest, otherwise you'll become restless.
That's a very deep way to finish there, Katherine.
Had to get a little bit deep for you, Forch.
Yeah, that's good. Hey, so there's a couple of good questions here that have come in. I haven't forgotten about the poll. I'll get that in a sec. But there's one around with someone that maybe there's a suspicion around, have they got some vestibular impairment? When would a therapist consider referring to someone with a subspecialty interest in vestibular physio?
So I think if they've got if you use VOMS, so that's a tool that's been designed for people without vestibular expertise. But if there's some findings that are significant on the VOMS, then I would be getting that ball rolling relatively quickly. If it's someone who's outside kind of 10 to 14 days of their injury. Within that period of time, there is a fair amount of people that do spontaneously recover. So if it was past that 2-week mark and there was some relatively significant things that you feel like were contributing to their symptom load, then I would be getting someone on board and getting them looked at. And personally, I love having someone come in for a one-off and then I can say, right, go back to your physio. Your physio is awesome. They're doing wonderful stuff. Here's some ideas of things you could tweak. And it can be a collaborative approach. It doesn't necessarily have to be you kind of handing them over.
Cool. If we just go back to that first case you're talking about, the guy with a 3-year history of being off work and whatnot, and how some of the treatments that you said improved his pain or he felt like he was better. How do you find that those types of treatments, how lasting is that effect? And so what's your sort of strategy to build on that and make a lasting improvement?
Well, it's interesting because I feel like the improvements that you typically get in the clinic, I think, are supplemented by what they do at home. But if they're coming to see you in the clinic, most of them don't do the stuff you give them at home because they're like, oh, I'm just going to come and see you and you're going to make me feel better. And so that guy was challenging from a buy-in point of view because he was quite irritable regarding his neck. But once he'd seen that link, I think that helped him realize the importance of doing some of these things regularly. I don't think he's going to be a miracle quick fix. Like, he's still got a long way to go. Don't get me wrong. There's a lot to unpack with that. But I think that, yeah.
It's maybe about giving a little bit of hope that he can.
Yeah, exactly right.
Yeah.
Exactly right.
Yeah.
It'd be had to have someone come in and say, look, don't know, can't really find anything. Good luck. Yeah.
Okay, and so with you're talking about the rugby case about training, preparing for contact and doing that in bunch-like pieces or little bites. So Anya's got a good question here about how do you retrain or improve the cognitive demands of a rugby player?
Yeah, and that's really tricky. And as far as I'm aware, the research is that as far as cognitive retraining, there was the Brain HQ team did a study looking at, it's like an app where you do brain sort of cognitive retraining. And I think they had about a 50%, I'm hopefully not butchering their research because don't know if I've seen it published, but I have heard anecdotally it was about 50% of people had a benefit from using something like that as far as it decreasing their return to playtime and things like that. I would say I look at it in two ways. If there's something else going on that you feel like is using up brain fuel, for want of a better word, and that's why their cognitive deficits are there, then you've got to address that cause, because that's probably the real crux of the issue. And a cognitive load on top of that is just taxing an already taxed brain. But if you've got someone and they've got relatively good function in those other areas, but it's really just this cognitive deficit, then look, if it was me, I would give these things a go. But the research isn't there to say this approach over that approach is going to be better.
Yeah, and I think that's kind of what we're doing every time we treat with someone with concussion, aren't we? So we're trying to create an environment where they're able to do as much as they're able without blowing up, supporting and encouraging cognitive recovery by not killing themselves with too much activity. So there are those specific cognitive retraining tools, but actually the entire nature or the recovery plan for most people's concussion does help that a little bit too. Anyway, I'll stop talking. It's your gig. Do you find the need to work on swallowing retraining hyoid work, say if bracing the hyoids for segmental flexors? I have to say I don't even know what that means.
Was that Karen? I haven't even looked. I bet that was that
It
Karen
was.
Regan. um, Karen's much more of a guru with that sort of what would be driving that. Personally, if I get someone who I'm trying to do deep neck flexor training with, and they describe some of those symptoms that I think all of those things that you just mentioned are probably involved, I cue them to try and switch off. So either press their tongue hard into the roof of their mouth while they're doing their deep neck flexor retraining. So if you do that, you kind of inhibit some of those muscles. Or I would think that I hadn't prescribed the exercise appropriately and that they can't do it at that level. So we've got to scale it back a bit. So that guy, I would get him doing it in supine to take gravity out of the equation.
Cool. I think maybe the last question for the night, so it's a good one as well, around when you're talking to people about vestibular training, have you got any suggestions about good resources or places to go to find materials that you might help support you?
Yeah, the VEDA, the vestibular disorders, I think it's just veda.org, is really good. They've got some really good patient level information on there. And that's probably the, I guess, one-stop shop that I would suggest. I do send people in some, particularly now with telehealth, direction of some YouTube links, but you've got to curate it a bit because there's a lot of rubbish out there. The Physio Tutors channel has some pretty good vestibular information on it.
Cool. Hey, well, guys, thanks very much for that. I'm sure that if there are any more questions, if you send them in on email or put them on Facebook, we can get an answer out to you. And thanks, Dane, for answering some of those questions. I saw you typing away. How many screens have you got, by the way? You look like you were sort of looking everywhere. It was ridiculous.
I got like 2 big ones. Lots of cutting and pasting.
Yeah, I bet. And then this poll, the poll's quite interesting. I think that should pop up in your screens, but it looks like, I'm sure most of you know that there's been some changing the way the regulations around allied health have been framed and what maybe you're able to do at level 3 and the way we think about that. So it looks like the majority of people out there are thinking about not seeing patients at level 3, 72%, and then there's 14% each not sure yet and planning to see some patients. So for those of you that think you might see patients, we did share, I think last time out, our SOP for level 3. So if anyone wants to have a look at that, it's just, there's nothing special about it, but it sets out some guidelines around when we can see patients, how we're going to see patients. We will be starting to bring more patients in at level 3. So we'll be running some injection clinics. We'll be getting people in for, assessing neurological exams and things like that, because frankly, we kind of need to, and the patients need it. So if we can help with any kind of information like that, don't feel shy about reaching out. We've got some of those things that we can share. And otherwise, thank you to you guys. Thanks, Dane, and thanks, Katherine, and thanks to all the good questions out there, particularly the one about the hyoid. And I loved it how you absolutely picked who it was without even knowing about it. I didn't even know we had a hyoid specialist in Auckland. So
Yep.
Yeah.
Karen's a specialist in all sorts of things.
yeah, okay. So I know where to go now with that. So I guess also, given that we're hopefully going to be at level 3, and it probably means that most of us still at home, we're planning on doing another couple of webinars, and so we've had some great suggestions about those. So I'll try and get a little bit more information about what they might be about out tomorrow. And hopefully this was a good one. I thought it was. I was particularly horrified about beer drinking and cheese and calories and stuff. I've been furiously Googling what a 1,500 calorie diet looks like. And
the only thing I heard from that was that you could be more moderate with women. So I just thought I could eat what I like.
Also something about as long as you eat it early, you should be sweet. So anyway, so there's a few key take homes from you and me that possibly reflect why patients don't do dumb stuff. They only hear what they want to. Anyway, I'll stop blithering. Lovely to see you all, and we'll aim to catch up next week, same time. Thanks, guys.
Keep down, everyone.
Thank you.
Bye.
See ya.